So next up, I'd like to invite Jason Trubiano to the stage. Jason is an infectious diseases physician and the director of the Department of Infectious Diseases and Immunology at Austin Health. He's the deputy head of Department of the Infectious Diseases at Melbourne Medical School. He's also the head of the You gave me such a long bio. He's also the head of the Centre for Antibiotic Allergy and Research and is a NHMRC Emerging Leadership Fellow with the University of Melbourne. Jason and his group lead antibiotic...
All right, well done, Felicia. I'm telling my EA to shorten that. Okay, thanks everybody for having me. I'm going to go through the changes to penicillin hypersensitivity. This does sit within the larger antimicrobial hypersensitivity guideline, but this is probably the most important, has informed recommendations in each section. I think it's probably catching up with where you all are in terms of your practice anyway at the moment, and hopefully will drive us a bit further forward. So I know it's very hard to see at the back, so I'm going to read out what's on the screen. But it starts off with some myth busting, and this does go along with the previous guideline that tried to explain why we're changing the way we do things in terms of antimicrobial prescribing in penicillin hypersensitivity. And the largest one is that if we see it in somebody's history, it doesn't last forever. And there was a lot of historical data that shows you lose penicillin allergy over the time, or you never had it in the first place. And there's actually nice modern data that's replicated that. And so these are papers where they've looked at penicillin skin test reactivity and challenge positivity over time, even in people that had genuine sounding reactions in the first place. And you can see with all our classes, they're really lost over time. And it actually goes back and mimics this actually seminal paper, I think, by Burke et al. In JACC in Practice 2015 that says what you see on the skin replicates what you find in practice. So I think we can use it as encouragement to challenge more people because of this loss of reactivity over time. The other big thing that is also the cornerstone of this is the definitions of antimicrobial hypersensitivity. The last guideline had a big change in terms of delayed and immediate, non-severe, severe. I think it was too much heartache to go through another change again. Maybe we'll get to non-severe and severe next time, or moderate, mild, severe, I don't know. But we're sticking with this. And the major reason, I'll go forward again, the major reason we're sticking with this is because we still think there's a difference in highlighting the severe delayed. That is a group where there is a lot less data about prescribing safety, and so we wanted to retain that ability to make recommendations around where we know a patient had DRESS or Stevens-Johnson syndrome. So that is predominantly the reason why we didn't group severe altogether, because they're not the one beast. So that is important, I guess, justification. The other thing is that urticaria we've learnt more and more is a bullshit sign, and so a patient that says they had urticaria in childhood isn't more severe to saying they had a delayed exanthem. And so we've moved that across to the non-severe immediate category, and that will open up prescribing opportunities as well moving forward. We've also linked out to some tools that since the last guide have got better evidence base and are more widely used in both Australian and international practices. And one of those is this antibiotic allergy assessment tool, a colour-coded system, green being low risk, orange being moderate, and red being high. The reason why this might match the guideline, it uses the same terminology: delayed, immediate, severe, non-severe, and a lot of those categories tick across. So if you are embedding this into your program or risk assessment for prescribing, this is why this was included, and so it's a slight change in terms of the link out. The big change, conflict of interest, clearly here, but we have added PenFast as the clinical decision rule in the therapy guidelines. And again, disclosure, I opened it up to the group and said, are we going to include this? And everybody said it was okay. And so this is a 3-point clinical decision rule that enables people to risk stratify patients in terms of directing oral challenge. And the guideline is more permissive now about encouraging direct oral challenge in low-risk penicillin allergy. So this is probably a big change, where the guideline has gone away from recommending particular clinical decision rules or guides. I'm going to say why. Well, why is because we have a lot of evidence now. This is the tool for those that haven't seen it before, 5 years or less, anaphylaxis, angioedema or scar or treatment getting points. We now have this international validation in terms of its negative predicted value, and now it's also been widely adapted in a range of settings. It's been used in pregnancy. I guess if that last talk, if there is syphilis in pregnancy, we should challenge those patients or test them or desensitise them. We should get to penicillin most of the time. ED, self-assessment, critical care, and also the inpatient setting. So there's sort of been an avalanche of people that have validated this outside of our group. It does not work in kids. So there is a proviso that we can't apply this to the paediatric setting. We need a new tool or a better tool for that setting. Okay, so this leads to the allergy testing component, and it's again very small text, but what it does do here is it links out to those tools, the risk assessment and PenFast. It's also got the figure there. It gives a set of criteria that you might consider challenging people. The clear one is childhood exanthem. This is somebody that should get a penicillin challenge and then definitive penicillin therapy. And so that is included now as a beefed up section in the new guideline. And I've just summarised it in the next point, those two major things that you would lead to a direct oral challenge. That's a PenFast score of less than 3, and again that childhood exanthem, which would be low risk on the allergy assessment tool. Okay. Now, PenFast was a way you can assess what evidence do we have of doing direct oral challenge, and thank God we've had a lot of trials that have come out after we met, but there is really now randomised control trial evidence for performing direct oral challenge. So if there are barriers to do this in the hospital setting, there shouldn't be. For the group at the back, got the top right-hand corner, which was the first randomised trial in outpatients with direct oral challenge. We then had the Palace study, which did it in a larger group of outpatients. We've got a middle trial, which is great in sexual health clinics, actually performing direct oral challenge in the intensive care setting in the top right-hand corner. And now just released last week was in perioperative outpatients where people are being challenged in that clinic. So we can't avoid the evidence base that we can do direct oral challenge, and it supports the guideline. The delabel rate is anywhere between 91 and 97% in that group without serious adverse events. And if we didn't need more evidence, there's now a meta-analysis. And I'm not going to go through that. It says the same thing. So hopefully that is helpful. One of the questions we got asked about as well, you're telling us we can do it. It's safe to do, but how do we actually implement that in our hospital setting? And so the National Antibiotic Allergy Network has created an inpatient guide, and Hannah was the first author out of South Australia. And this is a guide about how you practically implement those things in the hospital setting. And what I think is really progressive of therapeutic guidelines is that they've actually endorsed this guideline, and there's a link out to this. So it pairs with the prescribing guidelines and our recommendations, and there's a bit of a how-to. So I would encourage you to read that. Okay, the other cornerstone is cross-reactivity. This has been talked about for decades now. This figure was represented in the old guideline about the rates of cross-reactivity in those that report a penicillin allergy being under 2% for cephalosporins, under 1% for carbapenems, and non-existent with aztreonam, and it's a drug the registrars didn't know until now they compared it with avibactam. But these are the cross-reactivity rates, and they come from large meta-analyses, and we've referenced those in the guidelines. And what was also really supportive is the peak allergy body, probably internationally is the American group. They've got a strong recommendation that non-cross-reactive cephalosporins can be even used in anaphylaxis in patients reporting a penicillin allergy. I found this was a game changer for us also to be more progressive in that space, and so that does support our next component, which I'll talk about. So our recommendation is non-cross-reactive cephalosporins can be used in primary penicillin allergy, including anaphylaxis, again the caution with severe delayed, or otherwise known as SCAR. So we've gone away from this figure. Felicia did this, okay? So, and we've moved to the table, which I think is better because it actually tells you what drugs have a key practical cross-reactivity. And if you take away anything, and I've said it many times in my talks, it is those aminopenicillins and aminocephalosporins, amoxicillin, ampicillin, cefalexin, and C-chlor. And it gives some further detail about the cross-reactivity we know about some of the later cephalosporins, ceftriaxone, cefepime, cefuroxime, which share similar but not identical chains. So hopefully this is a good reference table for a quick guide. Can I give that drug? Are they cross-reactivity or not? If we overlay that with the recommendations, severe immediates, we're saying now you can use for directed therapy non-cross-reactive beta-lactams, i.e. penicillin anaphylaxis, ceftriaxone. In severe delayed, we're still saying avoid all penicillins and cephalosporins. I think the next guideline will move the needle even further on that. And then for non-severe, we're saying use all cephalosporins. Slight change as well. We're saying, look, it's non-severe, it's low risk. They probably don't have one in the first place, so don't worry about the cross-reactivity with cefalexin and C-chlor. Just go on and use those cephalosporins, which I think is also a progressive change. So how does it work in practice? So we've pinched some samples out of the guide, and again, two small to read at the back, but effectively this is a sample of septic bursitis, where we've recommended using a penicillin, and then we give text about what to use in the primary penicillin allergy. And the example I've used here is that it's saying to avoid cefalexin in somebody with a severe delayed primary penicillin allergy, even if they've tolerated cefazolin. Because I think people think, oh, I've tolerated cefazolin, but if they reported amoxicillin dress, we would not use cefalexin. The other one is in severe infections where we know that a beta-lactam probably offers a mortality benefit. So for example, here, I even can't read it, it's in staph bacteremia, I believe. We're saying use a non-cross-reactive cephalosporin, so that means use cefazolin and use, well, ceftriaxone you wouldn't use, but use ceftriaxone. So we're saying use a non-cross-reactive cephalosporin, even in severe immediate. So anaphylaxis to penicillin, Staph aureus bacteremia, okay for cefazolin, which I think will be a bit of a change for some people. And the last one is in meningitis, again a good example where in somebody that's known to have meningococcal meningitis or other where you want to use ceftriaxone, we're saying you can do that in the primary penicillin allergy that is a severe immediate. So again, some examples of where that might be some practice changing, particularly for local hospital guidelines. The last bit, I know I was given the topic of penicillin allergy, but I couldn't resist because I think this overlays with immunocompromised host management in particular. But again, in the time we were writing this, we had some more validated data and tools for sulfonamide allergies, which follows very much the same principles as penicillin allergy. And these are the new rules that all come from the same family, PenFast, Solfast, and now CefFast, same variables, same negative predicted value. So it does mean we can challenge a lot more patients with a primary sulfa antibiotic allergy and use a sulfonamide in that setting. And the last bit, I don't know, Amy, poor Amy had to do desensitization. Where are you, Amy?
She's gone home.
Oh, you're gone. So there was a big monster desensitization and a lot of work from Amy, but I think what the great thing is that's really been trimmed down now. It's a less complicated guide for desensitization and it gives practical examples and the key drugs that you're going to use. So credit there to Amy for doing that. But less is more. We wrote here the death of desensitization, delabeling the destroyer. So hopefully if you challenge more people, we really don't need to do a lot of desensitization moving forward. They haven't been thanked enough, really, particularly the two that worked with me, and putting up with me is a hard task. But thank you very much for Felicia and Jessica for their work. That's it.
I think we do have time for one or two questions if anybody has anything. Burning questions?
We had one on the app. Is that on? Oh, it is now. We had one on the app, which is, what age is adult for PenFast? Would that be 12 years old?
I wish. Are they big 12? I don't know. No, look, all the data is validated for 18 years, unfortunately. Okay. Clear as mud.
I was just wondering about interstitial nephritis and cross-reactivity there.
Yeah, we left that out, John, because all the derivation of PenFast and other clinicals will leave them out. My personal recommendation is cefazolin is safe, and there is observational data that cephalosporins are safe, but we left that out.